Good morning. It's really a pleasure to be here with Pim Cuijpers and talk about very important but elusive issue that is effectiveness in psychotherapy. We have been using words and relationship to support our fellow human beings for millennia, but it's still not clear what is really helpful and how this works. Pim Cuijpers is full professor of clinical psychology at Vrije Universiteit in Amsterdam and director of WHO Collaborating Center for Research and Dissemination of Psychological Intervention in Amsterdam too. Professor Cuijpers can be considered, if I may, the Miles Davis of meta-analysis in clinical psychology. So, as a matter of fact, he has published more than 1,000 papers and constantly contributes to our understanding of clinical psychology with several meta-analytic studies. So, Pim, if I may, I would say that you are the ideal interviewee when talking about effectiveness in psychotherapy. So, thanks for being here. And I will start with a few questions. So first one, by considering all the existing and sometimes contrasting evidence collected so far, do we really know how psychological intervention works? Because in your papers, you refer to diverse factors such as active components, moderators, and mediators. So how would you summarize the state of the art of what we know about?
First of all, thank you for having me here and for the kind introduction. I think regarding your question, I think we don't know how therapies work. We know that they work, but we don't know how they work. And that's true for almost any psychotherapy. The problem is that we can relatively well examine if therapies work, because we can use the idea of randomized controlled trials, which is basically an experiment. So it's the highest level of scientific evidence, because we divide a group at random into, and one of the groups we give the intervention and the other not. And then logically, after the treatment, we know that if one of the two groups differ, that must be because of the intervention. That's the idea of randomized trials. And so that's, we know that they work. Not too good, but they work from randomized trials. But that idea of randomized trials, that experimental design, we cannot use that to examine how they work. And we can examine mediators, we can examine for whom it works, we can do dismantling studies, but they all, in dismantling studies, we can use the design of randomized trials, but they need very large sample sizes, and they have not been done, hardly been done. So summarizing, we don't know from any therapy how they work. We know that they work, but we don't know how they work. And that's because the methods that we need to examine how they work is completely different from examining if they work. I can talk a lot about the type of research we need to examine how they work, but I think that goes too far for this interview. I wrote a paper about this in the annual review of clinical psychology, in which I explained why we don't know whether the common factors are indeed the active ingredients of psychological treatments. So if you want to know more about that and the reasons why it's so difficult to examine how therapies work, you should read that paper in 2019 in the annual review of clinical psychology.
Okay, thanks. And if we try to define if psychotherapy is effective in either treating or preventing mental health condition, what is your point of view about? Because several papers of yours have, I would say, challenged an often conservative look at this kind of problem. So I would be interested to better know what you think about.
I don't think there is doubt that psychotherapies work. They are effective. And that's not only true for depression, in which I have done most research, but for most other mental health problems, we have effective psychological treatments. And that's because that's also based on the idea of that you can examine the effects of interventions, whether they are, whether it's drugs or exercise or psychotherapy, they work. We can examine that with randomized trials. And there's no doubt, we know hundreds and hundreds of studies have shown that they work. So they do work, but many people who get the treatment don't get better. So it's better than not getting treatment, but they're not the solution for all problems. And that's something so we have a lot of evidence-based psychological treatments, and we know they work. So it's better to get them than to not get them. But it still means that a lot of people don't get better when they get the treatment. And they are effective, but not a solution for everyone. And that is, of course, a problem. Yeah, we know that because that's also what I will do in the presentation when I come to Bari. What we have done is we are collecting all randomized trials on psychological treatments of depression, but also many other mental disorders, so that we have all the evidence from randomized trials on psychological treatments. And then regardless of the target group, regardless of whether you compare psychotherapy with another therapy, with a control group like care as usual or waitlist, or with antidepressants or another drug, we include all randomized trials, meaning that we have all the evidence that can be known from randomized trials. We have that in our databases. And depression is by far the largest database. We have more than 900 trials now, but we have also all the trials in panic disorder, in borderline, and we're working on generalized anxiety disorder, social anxiety disorder, suicide. So we have all this evidence from randomized trials, and there is no doubt that psychotherapies work. There's no doubt whatsoever.
Okay, thanks. And what do you think are the least explored areas of psychotherapy? Because I have often wonder how much factors such as, for example, a training in a specific protocol or the involvement or a center specialized in this very protocol affect outcome more than overstudied factors.
Yeah, that's a very difficult question because, as I said earlier, therapies work, but they don't work in everybody, and that means that you need to treat people for example, in depression, we have looked how many people get better, respond when they get an evidence-based therapy. And that doesn't matter whether that's CBT, but there's also quite a lot of research in other therapies like interpersonal psychotherapy or non-directive counseling, but also psychodynamic therapies. And the brief psychodynamic therapies also work in depression. But if you look at the actual response rates, they are for usual care or waitlist, that's 16 or 17%, which is very low. And when people get a psychotherapy, then it's 41%. So that's much better than no treatment. But it still means that almost 60% of people getting an evidence-based treatment don't get better. And I think we should do much more research on what to do when people don't respond to a treatment. And for example, in depression, we've also looked at the remission rate. So response rates is when people get 50% better compared to baseline. So their symptoms are half of what they were at baseline. But remission means that people are completely better. So there's no difference with other people without a disorder. And the remission rates are only 25%, which is better than, again, much better than control conditions, but still 75% of people getting an evidence-based treatment do not get better. And all the research is focused on on an acute treatment of depression. All these 900 trials are aimed at examining what are the acute effects of treatments of depression. But we don't know what to do when people don't respond. And so we need much more research so that we can give people treatments when the first treatment doesn't work. And what do we do when the second treatment doesn't work? So the sequential treatment. Another thing that I think we need to do is step a little away from symptoms, because it basically is a very psychiatric approach, which has all kinds of advantages, because symptoms are very important for patients. But it's not the only thing that's important for patients. It's all, patients go into treatment because they are depressed, but also because they want to be a better parent, because they have all these problems at work and don't want to quit jobs all the time. They want to have a social network, and they're not capable of keeping. So they have all kinds of other problems next to the symptoms. And in therapies, we're very much focused on research on symptoms, while, of course, the other things are also very important. Yeah, so these are, I can give a lot of more priorities for research, but I think that actually these are two very important ones. Another one which I could mention is that we are very much focused on psychological treatments in high-income countries, while 80% of people with mental health problems across the world live in low and middle income countries. That means that, and in these low and middle income countries, the infrastructure for mental health care is not as high as in high income countries, meaning that 80% of people with mental health problems have very limited access to evidence-based treatments. And even in high income countries, the access to treatments is often not equally divided across, for example, income groups, but also minority groups have much less access to treatments, meaning that our treatments are actually only reaching a very small part of the people in need of treatment. So we need to focus more on all kinds of different ways of adapting psychological treatments so that they're scalable, to low and middle income countries, but also to groups who traditionally don't use psychological treatments. I think that's another very important. But if I would talk about priorities, I could fill.
Yeah, 1 year. We need all the day. Yeah. Now, coming to what you mentioned about scalable intervention, I was wondering if you can summarize your idea about possibly one of the most exhausting debates in psychotherapy, that is the one related to so-called other verdict, no? Because when talking about that, you mentioned this idea of the important scalable interventions.
Yes, indeed. Yeah, the Doderbud verdict, that's indeed a fascinating thing. It's a discussion that's been going on since the 1970s. And it basically started because all these, in the early phases, good trials showed that psychotherapies worked. Mm-hmm. But then they also found that they all worked to the same extent. And we see that now too, that in depression, we published a network meta-analysis a couple of years ago in which we looked at all these different therapies, and we found no significant differences between them, with the exception of non-directive counseling, but that's a different story. But so basically, the dodo bird says that all therapies are effective and that there's no difference between therapies, which is in a way is true, but that's not evidence that all therapies work in the same way. And as I said in the beginning, we don't know how therapies work. If we knew that, then we also would be much better answer the question of the dodo bird further. But we don't know. But one thing which is important is that we do find that all these therapies have comparable effects. So for me, the most important and interesting question is, what can we take away from treatments to minimize them without losing effects? And then you come to these fascinating new ways of delivering treatments. Like in low and middle income countries, they work with lay health counselors. So it's not psychotherapists, not clinicians, so to say. It's often nurses or people with another education. They're trained to deliver manualized, very brief psychotherapies. And they can do that effectively. There's a lot of evidence that they can do that. But you can also minimize, for example, the number of sessions. There is now this interesting development of single session interventions, which says that, okay, you can get one treatment and we're gonna explain the basics. And if that's enough for you, then please go your own way. But if you want more, if you want another session, we can extend that first session to the second session, and so on and so on. So in that case, you don't have dropout anymore.
Yeah,
and it's a way of lowering the threshold to psychological treatments. And of course, we have all the digital interventions, which are, and there's lots of research showing that digital interventions have comparable effects as manualized other therapies, usually CBT, but there is also evidence that other types of therapies can effectively be delivered online without losing the effects. Yeah, so that's about the dodo bird project. But if you want to know more about that and alternative explanations for the finding that all these therapies have comparable effects, you should read this paper in the Annual Review of Clinical Psychology in 2019.
Okay, so coming to what is possibly the area which you have conducted your best known research, that is depression. What do we know today about effectiveness of psychotherapy for depression in terms of major criticisms and important advances in published studies?
Yeah, as I said earlier, there's no doubt that psychotherapies work in depression. That's true for CBT. Half of the research on psychological treatment of depression is done in CBT. So it's by far the best examined type of therapy for depression. And it's effective, there's no doubt about it. But other types, like as I said, IPT or even dynamic therapies or behavioral activation or problem-solving therapy, they find comparable effects. And what I think is becoming more and more clear is that the effects of psychological treatments, we always thought that they are comparable to the effects of antidepressants. And that is also true at the short term. So at the short term, we don't find a significant difference between antidepressants and psychotherapy. They have comparable effects. However, at the longer term, there's now pretty strong evidence that psychological treatments are more effective at a longer term. And so I also see that in discussions in treatment guidelines, that there is more and more the recommendation to start with psychotherapies and not prescribe antidepressants without psychotherapy. Because so at the longer term, we've looked at that I will tell you more details in the lecture. When you look at research on treatments of depression, and you look at after 1 year, you have an acute phase where you give one treatment like psychotherapy or antidepressants or combined treatments, and then you have a maintenance phase in which you can switch or you can continue with the same treatments, but then you look at the outcome after 1 year. And when you do that, it's very clear that combined treatment is better than any treatment. The combination of psychotherapy and pharmacotherapy is much better than either psychotherapy alone or pharmacotherapy alone. But at 1 year, if you look at what happens with psychotherapy alone, that's still better than pharmacotherapy alone.
Mm.
So in treatment recommendation guidelines, we see, the discussions say now, okay, maybe we should not prescribe antidepressants alone, but only offer it in combination with psychotherapy. And if you want to do something as a first-line treatment without a combination, it should be psychotherapy, not antidepressants. And the evidence is pretty strong for this.
Okay. So, if I may, I have a final question. Coming back to what you have said today, it's a lot of intriguing information and stimuli. That is, in medicine, they try to target specific problems, so identified by biomarkers and so on. So I was wondering that from our side, that is from a clinical psychology point of view, we may need to improve our understanding of client requests and possibly of personality characteristics or traits of the client. They may affect the way they adjust to specific protocol and treatments, from more diachronic to more synchronic problems. For example, as you mentioned, they may be a person not interested in having now a long-term intervention, so they may ask just for a brief counseling, not necessarily delivered by psychotherapy. But on the other hand, the answer may depend on the way we ask what they are looking for, and trying to match the characteristics of the client with in terms of personality, for example, and the characteristics of the protocols. I don't know what you think about.
Oh yeah, I think this is a very promising area of research. I don't think yet there is very convincing evidence from biological treatment that some patients respond better to one treatment compared to the other, so that we can really personalize treatments. I don't think there is very much evidence that can be used. In psychotherapy, what we try to do is, the problem with personal characteristics is that one randomized trial never has enough statistical power to examine whether a therapy works better in this group compared to that group. So trials are always powered to find an effect. So, and then you already, that's often already a large trial. But if you want to examine moderators, so characteristics of patients determining whether a therapy works or not, then you need much larger sample sizes. And these trials are hardly ever done because they're so expensive. What we do is we collect the primary data from randomized trials in certain comparisons. And then we do have enough statistical power to examine whether for whom psychotherapies work better. And we've done quite a few of those. And they give very interesting personalized advice on who benefits from which treatment. And I will show that during my lecture, what some of the results are. But for example, we found very clear evidence that when you look at digital interventions for depression, they can be either guided, so then you have a personal coach helping you through the digital intervention, or they can be unguided, so there's no human support at all. And what we already found that if there is no human support at all, then the effects are much smaller than when there is some human support. And so what we found in such an individual patient data network meta-analysis is that in mild depression, it doesn't matter whether you give people a guided or an unguided intervention. But when severity goes up, so in more severe patients, then you do need to give a guided intervention in order to realize the same effects. And we've also found all kinds of other moderators of outcome, and from dropout, for example. So I think these individual patient data meta-analysis are a very good way forward to personalization of psychological treatments. We're not there yet. So when you have found these characteristics, you will have to test them again in randomized trials. That has not been done yet. But there are now all kinds of large new trials going on to see whether you can indeed find these moderating variables. But I will show you a few examples during my my.
So, Pim, thanks so much for all these comments and answers, very clear and opening to other questions that we're gonna talk about in Bari. So thanks again for being here, and see you in Bari in September.
Thank you. Looking forward to it.